Yes. Good evening, dear Professor and colleague. We will start the morning session, the evening session with two valuable speakers. We will start with Professor Bassem William. Professor Bassem William, he is the Associated Professor of Internal Medicine at Ohio State University, colleague of medicine, and the leader of T-cell lymphoma multidisciplinary cutaneous lymphoma program at Ohio State Comprehensive Cancer Center. He is a member of the National Comprehensive Cancer Network, NCCN, which considered as our guideline. Expert panel on T-cell lymphoma and immune cell therapy. Dr. Bassem will introduce a very interesting topic related to peripheral T-cell lymphoma, state-of-art management, and the future perspective. Dr. Bassem, it's our honor to join in 7th Ain Shams University conference. Dr. Bassem,
honor is mine. Thank you very much. Let me see, I can try share my screen. Can you see my screen?
Yes.
Okay, great. Thank you very much.
If you can put it into full screen, because now we are seeing the speaker's view and we can see the notes.
Okay. Let's try. How about now? Is that better?
It's not a full screen.
Oh, okay. Let me try again. Sorry.
Still.
No. Okay. Let's see.
Would you please to go right down?
Okay.
Reading perspective.
Okay, let me try. Okay.
In the right lower corner, sir.
Down to the right.
Okay. Perspective. I'm sorry. Let me stop sharing. Okay.
Okay.
Share screen. This one. And okay. And
okay. On the right lower side, just above the clock, there is a percent and
okay.
plus and minus. Just beside the minus sign, you will see the sign of full screen.
Okay. Is that better?
Yes, this is excellent. Please proceed.
Okay, great. Thank you very much. Sorry about the technical difficulty. I just want to start by saying I appreciate the kind invitation of the organizing committee. It's an honor of mine to speak to you today. I actually graduated from Ain Shams University a while back, and I was a resident and subsequently faculty with the Department of Medicine with the Division of Hematology. So it's a pleasure to be here. I would like to share with you some of the development in T-cell lymphoma. We'll start with some sort of basic concepts that I think are important. We talk about peripheral T-cell lymphoma. Where did that term came from? We know that was true for all hematologic malignancies. They recapitulate the cycle of development of normal hematopoietic cell. So T cells are born in the bone marrow, and they are travel to the thymus, healthy T cell, where they complete their maturation. So when we talk about peripheral T cell, we talk about T cells that are outside the thymus, because if a malignancy comes from T cells within the thymus, they're usually an acute lymphoblastic leukemia, lymphoblastic lymphoma type of malignancy. So anything that comes from outside the thymus, we call it peripheral, means come from the marrow or the peripheral lymphoid organ. And that's very important distinction, because for thymic malignancy, we are talking about leukemia, and we follow leukemia type management algorithms. We should start by alluding to the International T-cell Lymphoma Project, which was just an outstanding work that's longer than a decade ago. And that was an international collaborative effort across many centers all over the world, where they have a centralized pathological review of all cases of T-cell lymphoma prospectively as they came in. And they followed that with annotated clinical data, and they're basically trying to understand what is the prognosis of T-cell lymphoma, what are the prognosis of different subtypes. And as you see here from this pie chart, this will show you across all of those cases logged into that ITLP project. The commonest subtype was a peripheral T-cell lymphoma, not otherwise specified. You would see it here in the blue part of the pie, followed by the angioimmunoblastic, followed by the NKT cell lymphoma, ATLL, HTLV driven, and here you will see the anaplastic large C-cell lymphoma, ALK positive and ALK negative. So part of the difficulty that for that portion, as I'm going to allude to you later, this is a very heterogeneous group of patients. They have a very varied prognosis, and when we say generally in oncology in general, when we call not otherwise specified, it means that we don't know a lot about the biology of the disease to give it a more accurate terminology. So with peripheral T-cell lymphoma, it's important to highlight that about 10% of cases are incorrectly diagnosed. It means that the diagnosis is frequently challenging because most of the cases are extranodal. So many patients, they don't present with a classic lymphadenopathy that we see in B-cell malignancies. Many of them present as an advanced stage, and biopsies can be very confusing because as compared to solid tumor, when you biopsy a lymphoma, you're going to see a bunch of T cells that may not look very conspicuous or very suggestive of a malignancy. And here comes the role of your expert hematopathologist, who will be very essential in helping you reach an accurate diagnosis for your patient. As a general rule with all lymphoma, whether they're B or T cell, an excisional biopsy is really needed. Fine needle is not adequate. Fine needle can be helpful in solid tumors, but for hematologic malignancy, usually you get a bunch of lymphocytes, and then the architecture where they relate to the stroma around them is really key in reaching an accurate diagnosis. This is again from the International T-cell Lymphoma Project, and this shows you overall survival varied by subtype. And I think this chart is very important because if you can see here for the anaplastic large cell lymphoma, the ALK positive is up here. The prognosis is probably as good as diffuse large B-cell lymphoma, about 60% long-term survival. Next to it is anaplastic large cell lymphoma ALK negative, which is significantly lower, but still some patient would experience an extended form of survival. But everything else is down here. So all patients with peripheral T-cell lymphoma, with the exception of the anaplastic large cell histology, overall they do significantly worse compared to their B cell counterparts. We know from studying B cell lymphoma that prognostic scores are important. The trouble is there have been at least 4 or 5 different prognostic schemes trying to prognosticate peripheral T-cell lymphoma, but all of them have significant limitation. There is an ongoing prospective international effort trying to correlate cytogenetic and molecular findings. The IPI generally does not perform as well. The IPI was developed for B-cell lymphoma. The PIT score is perhaps the best that we have so far, but still have limitation. Realizing that this model is only helpful in peripheral T-cell lymphoma, not otherwise specified, but probably is not applicable to other rare histologies. This is straight from the most recent NCCN guideline for the management of peripheral T-cell lymphoma. And I'll walk you through this briefly, and then we'll stop and highlight what's the recent important development and how we think about managing these patients. So if you think about how you're going to manage peripheral T-cell lymphoma, in general, you should classify your patient to 2 categories. Do you have patients who have ALCL, ALK positive? And if you recall from the prior curves, these are the ones that are at the top of the curve and perform very well. And then there is everything else falls down here. So with ALCL, ALK positive, the general rule that those patients could be cured with chemotherapy without any additional intervention. So if you have stage 1 or 2, you can probably get away by doing 3 to 4 cycles. And we're going to talk about chemotherapy in a minute. Historically, we have used CHOP for those patients. I will show you some convincing data that we can improve on that slightly. And then you can follow that by doing radiation. If the patient has stage 3 or 4, you probably need a full of 6 cycles. And then after that, you do interim staging with PET or CTs. If you see a complete or partial response, then you're pretty much done, and you would observe the patient for relapse. If there's no response or progressive disease, then this patient pretty much dropped to this bracket. They're probably going to do very poorly. Everything else, we don't really have an established defined standard of care. Perhaps with the exception in CD30 positive cases. I'm going to show you some data about that. But generally, we like to accrue those patients on clinical trials because our so-called standard of care really does not perform very well. We know with anthracycline-based chemotherapy, any chance of long-term survival in peripheral T-cell lymphoma outside ALCL is probably in the range of 20 to 30%. So you would treat them with clinical trial, with CHOP or other regimen. If that's all what you have, you would do restaging. And if you have a complete or a partial response, we would, after the interim, you would complete your course, and then we would, if the patient still have a PET negative disease, we would recommend consolidation with high-dose therapy and autologous stem cell transplant. If they have anything less than a completely negative PET, those patients probably should fast track to novel therapies with clinical trial and perhaps consider them for an allogeneic transplant. This is a bit of an older data. This is from the German group, and they have studied across 2 individual clinical trials if we can improve on the classic CHOP chemotherapy by adding 3 days of etoposide, what we call the SHUAP regimen. A different iteration of that is the ASU-ICOC, which doesn't have as much data for T-cell as it does for B-cell. And you can see there have been an improvement in event-free survival. In both of their trials, there was no overall survival difference. And what's notable here that the benefit had only been seen in ALK positive patient. If you look at the curve here, there's probably some benefit in ALK negative and other histologies. It's close to statistical significance, but did not meet it, perhaps because of the low numbers. So generally, if we have a young and healthy patient who's not CD30 positive, so we cannot add brentuximab, so I'll show you in a minute, we would consider to give them SHUEP, despite that we don't have a definitive positive result from this trial, unless they're eligible for other clinical trials. Brentuximab vedotin, you're going to hear about it quite a bit in my presentation and also in the subsequent lecture on Hodgkin lymphoma. We think it have revolutionized the care of those patients. Brentuximab vedotin is an immunotoxin. It's an anti-CD30 antibody tagged to MMAE, which is a potent intracellular toxin. The whole idea about those kind of construct that this is extremely toxic, that if you give it systemically, it's going to kill the patient. So you target it directly straight to the cancer cell with the antibody. We define CD30 expression based on more than 10% by immunohistochemistry. I just want to give you a visual of two examples. This is an EBV-driven proliferation, which is typically very strongly CD30 positive. So you see, this is a very high intense level of CD30 expression. This is more a case of Hodgkin lymphoma, where you just see the expression right on the malignant cells. The first data for the efficacy of BV comes in a 58-patient trial of relapsed refractory ALCL. The overall response rate is 86%, which is fairly impressive. What I find most interesting about this, whenever you look at those survival curves, look at the end of the curve. Is there sort of like a horizontal tail end? When you see that, it means that some of those patients can be cured with this agent without doing anything else, because you see some flattening at the end of the curve. And when this data was updated at 5 years, there is still a significant 5-year overall survival benefit. So it shows that there's a proportion of patients who have ALCL that could be cured by BV alone. Although we would still recommend that if you reach some remission, you could consider those patients for consolidation with autologous or allogeneic transplant. This led or inspired the development of the Echelon-2, which is a large phase 3 trial in patients who have peripheral T-cell lymphoma of any histology who have more than 10% CD30 expression on immunohistochemistry. And those patients were randomized to 2 arms. A is the brentuximab vedotin, Adactris is a trade name, plus CHP versus the standard CHOP. And here, the BV replaced the vincristine in the CHOP combination. And patients were randomized 1-to-1. It was double-blinded, and patients were followed for progression-free and overall survival. The study met its primary endpoint, and there was a significant difference in progression-free survival between the experimental versus the standard arm. So brentuximab vedotin did improve PFS. And one key important secondary endpoint that it did actually improve overall survival, and that result is statistically significant. And that led to that we adopted that in the NCCN guidelines. So this became the recommended upfront regimen for patients who have peripheral T-cell lymphoma with more than 10% CD30 expression. There are different iterations of that we could discuss later if we have time in the discussion section. It's worth mentioning that in that trial, the vast majority of patients have ALCL histology. The patients who have non-ALCL histology were a much smaller number. So we still, if those patients have more than 10% CD30 expression, we would treat them with that regimen. But it's not objectionable that you could try something different if they have PTCL and have a borderline kind of CD30 expression. To make things even more confusing, that 10% number that we code to define CD30 positivity, we don't know if that's really all of that meaningful. This is one recent analysis looking at all of the trial conducted by the company that make brentuximab vedotin in PTCL, CTCL, and even in B-cell lymphoma. And if you compare patients who have less than CD10 expression versus those who have more than 10 CD30 expression, you're going to see the responses are not vastly different. So we don't know why that is. It could be a problem for the way we do the immunohistochemical stain. Maybe we need a better way of assessing CD30. It could be that the brentuximab vedotin doesn't necessarily only work on cancer cells, but it might also work on the stromal microenvironment and can modulate the patient's own immune system. We still recommend that all patients who enter remission after upfront therapy, with the exception of ALK positive ALCL, be consolidated with autologous BMT. This is the data from the Nordic group. Realize this is non-randomized data, but it's prospective data. And the tenet to that is right here. If you look at the 5-year progression-free and overall survival, when patients were consolidated with an autologous transplant, it's fairly high. We're looking at 50 to 70%. And if you compare that number to what we know about the long-term survival of patients who are treated with an anthracycline-based regimen without consolidation of 20 to 30%, you're going to get your answers. There is a 20% improvement in PFS and ES and overall survival. But realize this is, again, is a non-randomized data. It will be exceptionally hard to perform a phase 3 randomized trial in this setting, given how rare those diseases is, how different is the standard of care across different institutions and different countries. What do we do for relapsed disease? We have different agents we could use. The most popular is a histone acetylase inhibitor. Romidepsin, pralatrexate is a folate analog, and blinostat is another histone deacetylase inhibitor. I want to just bring to your attention here the overall response rate looks pretty puny. So looking at response rate in the range 20 to 30%, and you've looked at the response duration, they're also fairly dismal. So in essence, those agents, if you use them, you should have one or two things in your mind. What's the goal of the treatment? Are you planning to palliate the patient, prolong their life? If that's the case, you should use the agent that have the least amount of side effects, or you are planning to use it as a bridge to allogeneic transplant, and then perhaps you might be willing to accept more toxicity if you have an exceptionally young, fit patient and you have the ability to take them to allogeneic transplant. There are other agents that are available for your use. The two most promising things that are fairly new, duvelisib is still in development. It's already FDA approved for CLL. The early phase 1 data in peripheral T-cell lymphoma shows a 50% overall response rate. The phase 2 is ongoing. Azacitidine seems to be particularly promising, especially in patients who have angioimmunoblastic subtype. There is a high CR rate. Realize these are fairly small number, and these results need to be confirmed in the ongoing trials. Can we improve the outcomes? I think all of the data I've shown you, especially for a relapsed patient, looks fairly depressing unless they have CD30 expression. Certainly, if you have a patient who is in first complete remission, you would want to consolidate them with an autologous transplant. You could consider an allogeneic transplant in selected patients who are young and fit, and you have an available donor. We won't have time to talk in much in detail about the CAR T-cell efforts that are ongoing, but the three most promising candidate targets CD30 and CD7 and CD37. There's a whole bunch of clinical trials. It's just a list of the trials that I develop at our institution. Some of them are through more of drug company type of studies. Basically, we're just trying to develop novel combinations, trying to improve on that dismal 20 to 30% overall response rate and 6 to 7 months duration of response data that I showed you. I will spend 2 minutes to just touch base on angioimmunoblastic T-cell lymphoma. It's a subtype of peripheral T-cell lymphoma. Your hematopathologist can help you define it by a specific staining pattern. What's unique about that particular lymphoma? It can be very variable. Some patient can have a very indolent clinical course. There is a handful of patients I could observe without treatment. Many, though, have an aggressive course. It is associated with a marked autoimmune manifestation, hemolytic anemia, rash, arthritis, high ANA. It seemed to be sensitive to agents that are more immunomodulatory. So histone deacetylase inhibitor, romidepsin, and belinostat seem to work better in this type of disease. Dofilisib, which is the PI3 kinase in development, seem to have a higher overall response rate with AITL. Some of those patients have activated B cells in the background that you could actually add rituximab, which is basically a B cell agent. There's an earlier data with agent like cyclosporin or bevacizumab, given how vascular these tumors are. So I just want to finish by kind of telling you how I think about peripheral T-cell lymphoma, how we treat it. I hope I have convinced you that if there is CD30 positive disease, ALCL, ALK positive, you should add BV, brentuximab vedotin, to CHP. Just remove the vincristine based on the echelon-2 data. You could use SHOP or add etoposide or Schwab. Other histologies different from ALCL, if they have more than 10% CD30 expression, you give them BV. If they don't, if there is a clinical trial, that would be the preferred approach. If none, then you would use Schwab or standard CHOP. Hyper-CVAD can be used if you have an exceptionally fit patient who have CNS disease. There's specific regimen for a patient who have the enteropathy associated that we might not have time to discuss, but they incorporate methotrexate and ifosfamide. NKT cell lymphoma, more common in the Far Eastern country. They're probably extremely rare, both in Western country and also in the Middle East. But L-asparaginase seem to be critical to treat those patients appropriately. We recommend consolidating all patients in CR, with the exception of ALK-positive histology with an autologous transplant. With some diseases that are exceptionally bad, like NKT cell lymphoma, you could make a case of going straight to allogeneic transplant if that's available. At relapse, most patients do extremely poorly. If they have CD30, you could retreat them with brentuximab vedotin, even if you have used it upfront. Clinical trial is preferred. If they have a donor, if you have the ability to do allogeneic transplant, then you should sort of fast track towards that. And you could, or if none else, you could just try histone deacetylase inhibitor or pralatrexate. A few take-home messages that I think are important. It's really key that you have an expert hematopathologist to be able to diagnose those patients accurately. With the exception of ALK-positive ALCL, the prognosis of most subtypes is poor. However, we lack good prognostic models. In general, all patients with PTCL should be managed in a big university tertiary center of expertise in managing those patients. You need a high index of suspicion to diagnose those patients. Many of them, actually the vast majority, don't present with lymphadenopathy. They present with extranodal disease, and it could overlap with a lot of other systemic, autoimmune, or even perhaps infectious diseases. There are certain things that look very bad under the microscope, but they don't behave badly. And here comes the role of your expert clinician in consultation with the expert hematopathologist. Brentuximab vedotin is probably the best agent we have had for this disease for the past decade or so, and it now had a central role in management of CD30 positive diseases in upfront and relapse setting. And we certainly need collaborative international effort if we're going to make any progress in this disease. I thank you much for your attention. My apologies for the technical glitches and for going a bit over time. Thank you very much.
Thank you, Professor William, for your elegant, comprehensive talk. Let us to start with, please, two questions. First, do you recommend to use anti-CD30 in CD30 by immunohistochemistry negative pathology or not? As you illustrated beautifully, that even negative CD30 got benefit or achieved the response. This is the first. Second, with re-challenge with anti-CD30, if I used anti-CD30 in first line, is there a minimum duration, 6 months, 1 year, to re-challenge with brentuximab, or you can re-challenge at any time? Thank you.
Sure, these are great questions. I'll start with the first one. I think it's very reasonable to try brentuximab vedotin in CD30 disease unless you have a better option. So unless you have a novel agent, unless, for instance, you have a patient who have an angioimmunoblastic histology where they might benefit better from drug like duvelisib, or I have used duvelisib off-label if I don't have any other choices. Histone deacetylase inhibitor tend to work better with AITL. But if you don't have any other choice, I think it's completely reasonable. I have had patients who have like 0 CD30 expression by immunohistochemistry, and they had beautiful responses. I didn't get a chance to discuss cutaneous T-cell lymphoma, but patients who have cutaneous T-cell lymphoma with tumors, they tend to respond beautifully to brentuximab vedotin, even if they have a completely negative CD30. So I think it's totally reasonable. In regard to your second question, I don't think we really know. I think it's reasonable to re-challenge those patients unless you have other option. The conventional wisdom have been, and this is not unique to BV, it's true for any chemotherapy or immunotherapy agent. If they have progressed within 3 to 6 months from your last trial, it's probably reasonable to try something else. If more than 3 to 6 months have passed, and you don't have any other option, is very reasonable to retry. One word of caution: neuropathy tend to be a huge problem with brentuximab vedotin, and tend to be extremely unpredictable. So compared to vinca alkaloids, vincristine and vinblastin, the neuropathy with brentuximab vedotin can progress very fast from grade 1 to grade 5 within 1 cycle. So those patients I watch very carefully. As they start to develop any sign of neuropathy, I lower the dose immediately. For patients who have extreme body weight, there is a maximum dose that should be used. So all of those things are really key. And then the neuropathy tend to be cumulative. So the longer those patients are treated, the longer is the risk of neuropathy. That's one thing I factor in whenever I re-challenge those patients.
Thank you so much, Dr. William, for your comprehensive talk and valuable remark in question. Thank you. Now the floor to my dear colleague, Professor Ramirelli.
Thank you so much, Professor Lubna. I also want to thank you very much, Professor William, for your elegant and comprehensive talk. I still remember 21 years ago when I was a house officer, and I believe Dr. William was a resident of internal medicine. He used to explain to us the curriculum of internal medicine during night shift, and I still remember when he was explaining for us the ABG and how to manage metabolic acidosis. I still remember those days. I hope to see you soon in Egypt, Dr. William.
My
Thank you
pleasure.
so much.
Thank you very much.
It's my pleasure. It's my honor too. And now the floor is open to Professor Igor Ore. He's a professor of medicine at Medical School University of Zagreb and the Medical School University of Mostar, Bosnia and Herzegovina, and the head of the Division of Hematology Department and Internal Medicine in Hospital Zagreb Central. He is the chairman of the ERTC Lymphoma Group. He is the member of the steering committee of the European Hematology Association for Lymphoma Working Group, member of the European Lymphoma Institute. He's the chairman of the Lymphoma Committee, the president of the Croatian Cooperative Group for Hematology Disease, and member of the steering committee of the Croatian Hematological Society. A lot of titles, and we are all enthusiastic about his elegant talk as usual, because when we are speaking about Hodgkin lymphoma, I believe we are speaking always about Professor Igor in the treatment of relapsed refractory Hodgkin lymphoma. Sir, the floor are all yours.
Well, thank you very much. I must say I was very happy to receive your invitation. I was looking forward to come to Cairo, but unfortunately all this crazy thing with the pandemia made me stay at home and give this talk as best as I can virtually.
Perhaps this year, but next year we are insisting on seeing Your Excellency here.
Good, I'll hold you for that. Okay,
Sure.
I think I managed, right? You see my slides? So my topic is going to be treatment of relapsed and refractory Hodgkin lymphoma, and I thank you for the kind introduction. So we all know that outcomes in Hodgkin lymphoma are dependent on the age of the patient, and patients below 50 or 60 years of age have an excellent prognosis. But they're also dependent on treatment line, and those 10% or less of those younger patients who fail a frontline do have significantly worse outcome. In comparison to many other neoplasms, even patients who have failed one line can have a good prognosis, and a substantial number of them can be cured, which cannot be said for those who fail 2 lines of treatment. So what are the recommendations for treating patients who are young, can receive any treatment that is available, and have failed 1 line of treatment for Hodgkin lymphoma? And there are European recommendations by the European Society of Medical Oncology, which have the disadvantage that they're very slow in making. And the last version appeared in 2018, and there have been happenings since then. So they're not quite the newest, especially if there's something very new going on in the field, which is not the case for the American, which are put forward new even a few times a year. And we also have Croatian recommendations, which try to be faster than the European. So if you look at all 3 of them, what you see is if you have a patient who failed frontline Hodgkin lymphoma, he or she should get high-dose chemotherapy and undergo autologous stem cell transplant. And then to a lesser extent the European, and to a bigger extent the American and ours, say, well, and yes, do use radiotherapy for anything that does not look like being in very good complete remission. Where does this fascination with high-dose chemotherapy and autologous stem cell transplant come from? Actually, the number of studies that have been performed randomized is rather limited, and the size is small. And if you look at the level of evidence that would be generated from those randomized studies, it's not very high. But there's a large amount of real-world data suggesting that, yes, doing this is the best way to go forward. And it's also important to keep in mind that despite the idea that if you have an early limited stage relapse, you might try to cure it with a little bit of chemotherapy and radiotherapy. If you do give high-dose chemotherapy and autologous stem cell transplant, you will in the long run always have better results than if you try to avoid this type of approach, irrespective of the stage and extent of disease in the relapsing patient. And all the studies and almost everyone in the world is actually using the combination of carmustine, etoposide, cytarabine, and melphalan or cyclophosphamide as the conditioning regimen. That was true until a few years ago when we have had problems with carmustine availability in Europe. So now we have some data suggests with carmustine being changed to bendamustine, and the results have been mixed. Some say it's better, some say it's the same, and some say it's worse. So the jury is still out. The toxicity is somewhat different than with combust. So when you start and give chemotherapy, should you always go to autologous stem cell transplant? And the answer to that is no. The patient, as always, when you go to such a treatment, has to respond to the chemo. And in the pre-PET era, being in partial remission and complete remission didn't really matter very much. But now with PET, it seems that PET negative patients do fare significantly better than PET positive, who are in partial remission. But still, the PET positives do not go totally badly. So this is also something that one can consider going to an autologous stem cell transplant if there's no easy and fast and sure way to get a PET positive patient who is in partial remission into PET negativity. Of course, you noticed I didn't talk at all about which high-dose chemotherapy regimen to use, and that is because there have been a number of them described in the literature, and they all have more or less the same final outcome, which is progression-free survival. Even if you look at what was at once very popular, the Italian IGEV, which had kind of a very good response rate, 80%, 54 complete remission percent, which is higher than with ICE or with DHAP. If you look at the duration of response, at the event-free survival, it's pretty much the similar. So this was kind of more due to the fact that they were giving 4 cycles of IGEV and 2 cycles of DHAP. So the tumor mass did not was not reduced when used CT scan, and in PET it would end up being the same. So all of these regimens give approximately 60% of PET negativity in relapsing patients, and you can use the one that you're most familiar with, or those that is best suited to avoid toxicities you want to avoid in your patient. And the outcome after transplanting a responding patient and giving radiotherapy to those areas you think are in need is the curve shows a plateau after about 2 years. So there are relapses even after that, but they are few. And most patients who have not relapsed within 2 years after an autologous stem cell transplant can be considered cured. Prognostic factors for relapsed Hodgkin lymphoma, they have been the German and the American criteria, but they're really very similar. So short remission is bad, having stage 4 is bad, and then having anemia and these symptoms is bad. And patients who have none of these respond very well to standard second-line therapy, while those who have all of them do significantly worse. What about radiotherapy? Well, it's a very effective, it is the most effective local therapy for Hodgkin lymphoma. And it has little acute toxicity, but it has no systemic effects. So it should be used for local disease after systemic disease has been reduced to a minimum by chemotherapy. And if you read what experts recommend, some of them say, well, you just give it before autologous stem cell transplant. Some say give it after autologous stem cell transplant. Some say, well, give to all relapsing sites. Some say just give it to those that did not respond completely to chemotherapy, and so on. There are really no studies, and it's hard to say one is better than the other, but I think what is important is keep in mind, just give it to those areas that are in need, and you don't need to go over the standard dose for Hodgkin lymphoma, which is 36 grays. And yes, there are no randomized trials, but all expert opinion and all real-world evidence suggests that it is certainly useful. Besides radiotherapy, now we have a more expensive way of converting PR into CR after autologous stem cell transplant and improve the outcome, the progression-free survival of high-risk patients, and that is giving brentuximab vedotin. And this is the seminal study. I'm sure you've seen the slides. What one should notice, it reduces the number of relapses by 2 times, so there are 2 times less number of relapses if you give brentuximab vedotin after autologous stem cell transplant, but there is no advantage in overall survival. And the factor that was most prominent as being the group that did not benefit from BV was those that were PET negative after high-dose chemotherapy, so pre-transplant, and with the possible exception of patients with stage 4 disease at relapse. So these are the 2 main risk factors for we consider when using BV as consolidation, as not being in complete remission prior to autologous stem cell transplant and having stage 4 disease. And also those that rarely respond completely are the primary refractory Hodgkin lymphomas. So what happens now? About half of the patient can be cured in second line, 2/3 of those who have late relapses or who have relapsed, and about 1/3 of those who are primary refractory. So there is a population of patients that need something more than something beyond second line. And we all know standard in all the developed parts of the world, those who can afford it, is brentuximab vedotin. And it does work, but what it probably does not is cure the patient. So the median duration of response is 10 months, except perhaps in those that achieve complete remission. And therefore, most experts would recommend, once you get a response, to BV consolidated with stem cell transplantation. Autologous if the patient was not transplanted before that, or allogenic if the patient failed autologous stem cell transplant. Now, we all know we use rituximab, and rituximab is almost always combined with chemotherapy. Can we combine brentuximab vedotin with chemotherapy? And the answer is yes. A low-intensive regimen is bendamustine, and full doses of both agents are well tolerated. And you can even combine it with more intensive chemotherapy with one you would use as salvage in second line. And it also works pretty well with somewhat more toxicity. And again, this latter approach should always be used as a bridge to transplant. And then for fourth line, and maybe even third, we can discuss that later, is the PD-1 blockade, which is more frequently used for treating solid cancer like melanoma and renal cell carcinoma. But actually, Hodgkin lymphoma is the disease that is most sensitive to PD-1 blockade. Over 90% of Hodgkin lymphomas have mutations of PD-1 ligand and are extremely sensitive to this blockade. The dose is standard. The response rates are around 2/3, and progression-free survival is around a year and a year or 2. There are no major differences between nivolumab and pembrolizumab. I believe they can be used, they can be interchangeably used. What is different from standard approaches to treating Hodgkin lymphoma is toxicity. So we do not see the hematological toxicities we see with high-dose chemotherapy. We do not see neuropathies. So we see with brentuximab vedotin, what we see are autoimmune phenomena that are usually mild, but can in some cases be even lethal, especially the pneumonitis. And again, unfortunately, there does not seem to be a plateau, a sign of curing patients. So what are the cheaper ways of treating patients? So without these new drugs, can we do something when the new drugs have failed? And years ago, of course, there were these palliative approaches with using repeated doses of vinblastine or using gemcitabine monotherapy. Sometimes the latter did wonder in our hands, but the responses are around 1/3. And but even with these approaches, you can get like a 2-year overall survival, which is not so devastating as it might look upfront. Okay, so, but a lot of patients with Hodgkin lymphoma are young, and even though they failed 2 lines of treatment, we would still like to save them and cure them. How can we do that? And there's a method that looks like, this is from Shakespeare. I think he was describing allogeneic stem cell transplantation. And the fact is, it works in Hodgkin lymphoma. It works. The best way to do it is to use a reduced intensity conditioning and a haploidentical related stem cell transplant, as developed by the Johns Hopkins group. And these are our results in the few patients that we had to do that failed the 2 lines of treatment, with very good progression-free survivals for these category. But again, as in autologous stem cell transplant, patients need to be in good response for a stem cell transplant to work. And the way you introduce this good response is irrelevant. So we use chemo, we use brentuximab vedotin, or we use a PD-1 blockade. It doesn't matter. Only, with PD-1 blockade, you should wait for 6 weeks or so because of the reported high incidence of GVHD if you go immediately to an allogeneic stem cell transplant. So these were all standard data. So what is new, what is not in the recommendations, what is not standard, but the data is there. There have been a number of studies in second line where to the standard high-dose chemotherapy brentuximab vedotin was added, which was the European approach, or the American, which added brentuximab vedotin to nivolumab, or vice versa, whichever you want to say. And it seems that 20% better than what you get with high-dose chemotherapy only. And the differences in 2-year progression-free survival also look, let's say, 15%, approximately 15% better. Unfortunately, there is no randomized study comparing this type of approach with the standard approach. And it's a big question whether the European Medicines Agency will accept such data and license brentuximab vedotin for use in second-line Hodgkin lymphoma. So we now face the paradox that it's licensed for third line and beyond, and also for first line, but not for second line in Europe. And there has been a randomized study that was presented at this year's European Hematology Association plenary session that was comparing brentuximab vedotin and pembrolizumab as in the standard BV indication, that is patient failing at least 2 lines of treatment. It was a quite big study with 304 patients and a median follow-up that was longer than 2 years. And the results suggest that progression-free survival is improved by using pembrolizumab in this indication instead of BV. The relative risk seems to be similar in all prognostic subgroups, but there does not seem to be a difference in overall survival. Toxicity is similarly frequent, but different in types. And the only treatment-related mortality was actually a death of pneumonitis in patients treated with pembrolizumab. Well, of course, with brentuximab vedotin, the biggest problems are neuropathy and neutropenia. So I think I'll start my conclusions here. High-dose chemotherapy and autologous stem cell transplant with the liberal use of radiotherapy and possibly addition of brentuximab vedotin is standard second-line treatment, which results in cure in about 2/3 of relapsing and 40 to maybe 50 with the addition of BV % of primary refractory patients. There does not seem to be any substantial difference between standard high-dose chemotherapy regimens. So you can use ICE, DHAP, ESHAP, whatever you like and are familiar with. For those who failed 2 lines of treatment, the combination of brentuximab vedotin, possibly with bendamustine, or if you want to go to another stem cell transplant, another salvage regimen is an option, or PD-1 blockade. But remember, the duration of response will be limited and consolidation with the stem cell transplant, including allogeneic, is warranted. And it seems, although it's not registered and not available in Europe, that the addition of BV to high-dose chemotherapy leads to increased responses in second line of treatment. But And always I talk about Hodgkin lymphoma, where I say, look, optimal approach to relapse and refractory disease is avoid happening. Cure the patient whenever you can with frontline therapy. And thank you. I'll stop there and try to answer your question.
Thank you so much, our dear Professor Igor. It was a crystal questions, but I find a lot of thank you. It's so elegant. Everybody is thanking you, and everybody is grateful for this talk. It was crystal clear.
Would you please to ask a question?
Professor Lobna, yes.
Yes. Would you please? Thanks a lot for your elegant, comprehensive talk. First question: what is the permissible number of sites to be for radiotherapy? Permissible to be given radiotherapy? It's 1, 2, 3. As in your presentation, unlimited sites can be given.
Well, you know, when I started practicing medicine, we were still giving mantle field. Nowadays, I guess no radiation oncologist would give mantle field, but that if you ask that for a frontline patient, I would say, well, you know, 2 or 3 areas. Do not go over 3 areas of lymph nodes. But in a salvage setting, it's a question of life and death. And then the toxicity issue, I think, becomes less prominent. Personally, I don't think, you know, irradiating more than 3 sites is useful, because then the disease will come back somewhere else.
Yes.
But it's just, you know, formal. My idea. I have no data to support that. No good data.
Your opinion, please, regarding allogenic transplant after immunotherapy and the rest of graft injection. What do you think?
We do it. So the patients that fail second-line treatment NBV, we give PD-1 blockade, and then when they respond, we go to an allogenic stem cell transplant. We try to postpone it for, let's say, 6 weeks if possible. It's not so much the problem with graft rejection. There have been reports of very severe GVHD in patients that have received a PD-1 blockade prior to the allogenic stem cell transplant. Saying that, it seems that if you use high-dose intensive GVHD prophylaxis, including the post-transplant cyclophosphamide, as is done by the Johns Hopkins regimen for haploidentical transplantation, then this danger is far less.
Yes. The last question, please. Maintenance of Bambro after allogenic transplant in patient who is previously progressed on CD30, anti-CD30.
Well, you know, if you progressed on progressed on brentuximab, you went to the allogenic stem cell transplant, and you are PET positive, you're in a bad shape. We try everything we can,
okay,
including sometimes, yes, repeating BV. I can't say we have. Well, they're just, you know, a couple of these patients. We can't say a lot. Sometimes it helps, but usually not for very long. So, but then, you know, you have these games with giving donor lymphocyte infusions, irradiating, and so on and so on. Yeah, you can do it. It's not very good.
Thank you so much.
We have another question. Thank you so much. We have another question from our dear colleague, Dr. Nirimi Mustafa. She is asking you, in case of relapse, do you suggest taking a biopsy before starting?
If we try, yeah, we always. Sorry, can you say that again? Whether I suggest to take a biopsy?
Yes.
Yes, we always try to get a biopsy. In every type of lymphoma, whenever we have a relapse, we always try to take a biopsy, and especially in cases where the probability of relapse was rather low, like having a PET negative Hodgkin lymphoma that relapsed fast, then we always are suspicious of something else happening, and occasionally you see some quite unexpected diagnosis. So yeah, whenever the course is not clear, try to get a biopsy, even surgically if you cannot do it otherwise.
Yeah.
Okay.
Okay. Thank you so much.
You're welcome. Thank you.
We wanted to see you face to face next year.
Looking
Okay.
forward.
Okay, thank you.